If it is not pumping properly, the condition is called the decompensation or failure of the system or failure of the heart. Scenario is in front of you: a 50-year-old non-diabetic alcoholic recently arrived from the North America, presented in the medical OPD for breathlessness on slight exertion for the last 2 months. He recently noticed the puffiness of the face in the morning, and on examination, temperature is 99 degree Fahrenheit, pulse is 112 per minute, blood pressure is 174 by 120, and he's got the pedal edema, positive S3 audible at the metal area, hemoglobin was 10 gram, and total leukocyte is 5,400, platelets is 3,20,000, XHS revealed minimal cardiomegaly with obstructed right-sided cardiophrenic angle. Now the heart data in this condition is the patient is already comorbid with diabetes, he is alcoholic, he is arriving from North America. Probably he acquired some disease from the North America. And he has got now breathlessness, which is escalating now on slight exertion for the last 2 months. And he had got the positive findings of high blood pressure, stage 2 hypertension, and he has got the sinus tachycardia with edema which is positive, and third heart sound is audible at the mitral area. He was anemic and has got the evidence of cardiomegaly on X-ray chest with the evidence of pleural effusion on the right side. Now this is the story given in front of you. Now these type of stories we usually see in our OPDs, medical OPDs. The questions arrived from these type of presentation which we used to see in our OPDs. There are about 10 to 15 patients per month. I usually see about 15 patients or 17 patients per month of these type of presentations. That is breathlessness which is escalating, and there are positive findings on which I have already elaborated in front of you. What is the differential diagnosis? How you further investigate this case, and what is the most likely diagnosis, and how will you manage this case? Now this is the case of a failure of the function of the heart. That is pumping effect, the pumping failure of the heart, and that is called the cardiac failure. Because it is a failure of globally, all chambers are affected probably. It is called total cardiac failure. It is also known as congestive cardiac failure because it will lead to the congestion in the different parts of the body. In the heart failure is a condition in which the heart cannot pump enough blood to meet the body's needs. In other cases, the heart cannot pump blood to the rest of the body with enough force. Some people have both problems. The term heart failure doesn't mean that the heart has stopped or is about to stop working. It is a wrong impression given in front of the patient. Failure means decompensation. It doesn't mean to stop. अगर किसी को पता चले जो हार्ट फेलियर होगा उसने कहा कि मैं तो मर जाना है, इसलिए in front of the patient we will not talk of this specific terminology. We can use CCF, or we should use the decompensation of the heart. Now the causes of this failure are manifold. Of the heart failure is concerned, the common one is the coronary artery disease, hypertension, cardiomyopathies, valvular heart diseases. Less commonly arrhythmias, different type, collagen vascular diseases, endocrine diseases like hyperthyroidism, pheochromocytoma, and also the myocarditis or associated with pericarditis, restrictive cardiomyopathies, or volume overload or heart failure decompensation. It is called high output cardiac failure. You see in anemia, you see in cases of fistulas, you see in hyperthyroidism, and you also see in fluid overloads. There are pulmonary causes also, that's copulmonale. These are high output type of the cardiac failure. It is a volume overload, it is not pressure overload. So these are the causes of the heart failure, or you can say the predisposing causes. Classification according clinical classification, depending upon how much breathlessness the patient has or the symptom. The class 1, according to the New York Heart Association, we classified this patient. Class 1 is symptoms of the heart failure or breathlessness only at the levels that would limit normal individuals. Class 2 are the patients of breathlessness with ordinary exertion. Class 3 is the symptoms of the breathlessness on the less than ordinary exertion. And class 4 are the symptoms of the breathlessness at the rest. So the classification of the heart failure according to the American College of Cardiology guidelines, rather they are, stage A is high risk high cardiac. Now this classification is depending on the severity of the disease. Stage A is a high risk of the heart failure without any structural heart disease or symptoms. Stage B are the heart disease with asymptomatic left ventricular dysfunction. Stage C are the prior or the current symptoms of the heart failure. And stage D is the advanced heart disease and severely symptomatic or refractory heart failure or resistant type of heart failure. This is a vicious cycle. The left ventricular dysfunction causes the decreased cardiac output. It will cause decreased blood pressure and decreased renal perfusion. And decreased renal perfusion will cause the release of the renin, which is enzyme released from the kidney. It will convert angiotensin 1 to angiotensin 2. Angiotensin 2 then stimulates the aldosterone, and aldosterone will cause the retention of the sodium and water on the distal convoluted tubules. So there is retention of the fluid and salt in the failure. The clinical presentation of heart failure is due to the excess fluid accumulation. The presentation is dyspnea, the most sensitive symptom. It may be external dyspnea, it may be orthopnea when he lies down, or on the lateral side, it may be possible, or it is maybe due to the hepatic congestion. The patient doesn't feel appetite, and there are accumulation of fluid in the abdomen, ascites, and there is very important symptom which is there, because it is one of the sign cure of the disease, that is paroxysmal nocturnal dyspnea. It is the heart data of the heart failure. A second type of the clinical presentation is due to the reduction in the cardiac output, like fatigue, especially with exertion or weakness, and you cannot concentrate well because the blood will not go into the brain properly. Cerebral perfusion pressure will become low. On physical examination, there will be S3 gallop, and there will be cool, pale, cyanotic extremities. You will find tackles are seen. There is fine capitation at the base of the lungs, and elevated jugular venous pressure will be there. Lower extremity edema or dependent edema will be there. Ascites, hepatosplenomegaly, splenomegaly can be there, and you will also find the displaced apex beat. The heart is large because the impulse you will find mostly in the 7.5 centimeter to the mid-sternal line. Now it is displaced to the 10 centimeter or more than that from the mid-clavicular line. So these are the physical examination which is presented in front of you. Now this is the jugular venous pressure which you always measure. It is increased in all cases of the failure, especially in cases of the right-sided predominant failure, right-sided failure. Lab analysis in the heart failure will be done with like the CBC, serum electrolytes and creatinine should be done. The fasting blood glucose thyroid function test to exclude the primary cause of the heart failure. RNA studies, the patient is anemic or not. ANA profile. Autoimmune diseases can cause the problems, vasculitis, and ultimately leading to the ischemia of the heart and heart failure. And viral studies, because the cocci virus will act on the myocardium, it will cause cardiomyopathy, dilated cardiomyopathy, and this can cause heart failure. Now PNP is an enzyme which is released. This is atrial natriuretic peptide. Now it is called the brain natriuretic peptide now. With the chronic heart failure, the atrial myocyte increase amounts of atrial natriuretic peptide and the brain natriuretic peptide in response to the high atrial and ventricular filling pressures. Usually it is 400 picogram per ml in patients with the dyspnea due to the heart failure. It may be in thousands. But it is not the diagnostic point. Remember. Two things to remember always. Increase in ANP or BNP is not diagnostic always. An echocardiogram which shows the less ejection fraction is not the diagnostic point of the heart failure. It is the total patient which will tell you. The whole scenario will tell you. And there is a what is called as the diagnostic protocol which will tell you the patient is in heart failure. The chest X-ray in heart failure, there will be, you see the cardiomegaly, and there are a lot of findings in the X-ray. You see there is a cardiomegaly, whether it is predominantly right-sided or the left-sided or both. Here in this X-ray, there are a lot of congestive changes are seen. Upper lobe diversion is seen. That is called cephalization. And the other findings are also seen, which we will discuss very, very late. When you will come in final year, we will discuss these things. Cardiac testing in the heart failure electrocardiogram will show the many points can be found. It may be a low voltage ECG with the left axis deviation, left ventricular dilation, left ventricular hypertrophy, left bundle bound block, and others. The echo will show the left ventricular ejection fraction. I said it is not diagnostic, but it is reduced in most of the cases, not all. Our structural and the valvular abnormalities, comorbids can be picked up on echocardiography. This is the ECG which shows in this. The most important thing is the R wave is not progression from V1 to V6, non-progression of R wave. It shows that this is cardiomyopathy occurs in this patient. Secondly, there is left axis deviation in this patient. It shows the heart is diverted towards the left side. And R wave is very, very rarely seen in most of the leads are means the depolarization of the left ventricle. It is weak. It shows the weakness of the contraction of the heart. Common physical signs in congestive cardiac failure. If it is predominant left-sided failure, you find restlessness, confusion, orthopnea, tachycardia, exertional dyspnea, fatigue, cyanosis, paroxysmal nocturnal dyspnea, elevated pulmonary capillary wedge pressure if you go for catheter studies. Pulmonary congestion will cause you the cough or crackles, that is fine crepitations at the bases of the lungs. Wheezes can occur and blood change sputum can be seen, tachypnea or platapnea, these type of things, orthopnea. These are the few signs and symptoms in the left-sided failure. As far as right-sided are concerned, there is the high JVP is the main thing which is there, high, and you will find in the right-sided failure secondary to the chronic pulmonary problems due to and anorexia, weight gain, edema is much dependent edema, enlarged liver and spleen, and the liver may be pulsatile, and the peripheral venous pressure they are increased. How to diagnose the latent cases of CCA? These are the clear-cut cases of CCA which I have presented. If these cases, these findings are there, it means that this is cardiac failure. But I am talking about the persons who have not the clear-cut symptoms or signs of the congestive cardiac failure. In which case we apply what is called as Framingham criteria. This is a very useful criteria in diagnosing the latent type of a congestive cardiac failure, or the failure is not very eminent. It is not eminent to the physician. Here, this is the criteria in which the two major criteria or one major or two minor criteria, if there, the diagnosis will be done. The major criteria is paroxysmal nocturnal dyspnea, orthopnea, elevated jugular venous pressure, crepitations, S3 third ultrasound, radiological evidence of cardiomegaly, or radiological evidence of pulmonary edema. These are the major criteria. If two is there, you will diagnose. The minor criteria is stimity edema, dependent edema, nocturnal cough, exertional dyspnea, hepatomegaly, pleural effusion, heart rate is more than 120. Another important thing is that there will be loss of 4.5 kilogram of the weight in 5 days following diuretic treatment. This is the only condition of the world in which there is so much weight loss after giving the diuretic. This is the only condition in which the 4.5 kilogram weight will be reduced after giving diuretic. This confirms the diagnosis of the heart failure. The management number one is complete bed rest. It should be done for 2 weeks at least, and the patient should be comfortable in which position he or she wants. Otherwise, the best is that the head should be raised, so it is more comfortable. Otherwise, the orthopnea will worse. Second point is the reduction of salt. Only 800 milligram per day is required. It is allowed. Stop the salt. Restriction of the fluid. Not more than 1 to 1.5 liter per day. The patient should take in pits ओनली. वो मुंह भर के पीना नहीं है, थोड़ा थोड़ा करके पानी पीना है. 1.5 लीटर्स, 1 to 1.5 लीटर्स. सो द लोड जो है ना लेफ्ट वेंट्रिकल शुड बी रिड्यूस्ड. Fluid restriction should be done. I have said the reason of it. And now the management of the reduction of the preload. Now preloaders, the load before the blood comes into the left ventricle or right ventricle, it should be reduced. How it is reduced? By giving the diuretics. And there are a lot of diuretics. It may be the diuretics which are loop diuretics, or it may be the diuretics which act on the distal convoluted tubules and losing the sodium and potassium, like hydrochlorothiazides, and the other diuretics like the carbonic anhydrase inhibitors, or the aldosterone antagonists like spironolactone, or aldosterone receptor blockers like eplerenone. Potassium sparing diuretics are available like trimetine and amiloride. And osmotic diuretics are mannitol and glycerol, isosorbide, etc. You can give one diuretic if patient can be relieved by one. If it is not relieved by one diuretic, you will combine two. You can combine 3 diuretics even to reduce the preload. The patient will be benefited almost with the bed rest and salt restriction, fluid restriction, and with the diuretics. 80% of the patient relieved with the symptoms. 80%. Other things you could do is the reduction of afterload. It's a very acute condition. We use the sodium thiosulfate, sodium nitroprusside, But in the other situations, we give the ACE inhibitors, mostly, captopril, enalapril, etc. Or we can give the nitroglycerin, isosulfide dinitrate, venodilators, or we could arterial vasodilators like hydralazine and prazosin, etc. The best one is the captopril, followed by the long-acting drug like valsartan. That is the best choice. If it is not managed by this, you will use the inotropes. The inotropes are many types. Digoxin is one of the best drugs invented ever in the world. Because of the side effects of the digoxin, there is a monitoring difficulty. That's why digoxin is not usually used. We will discuss in the final year how it acts and why it is not used commonly. If the BP is low, the hypertensive and patient is there, you use the dopamine or dobutamine or epinephrine or norepinephrine, milrinone or isoproterenol, etc. These drugs are rare drugs which you use. And the use of the antiarrhythmic agents should be given, because there are a lot of chances of arrhythmias. And we use the cardioselective type of the intrinsic sympathomimetic activity beta blockers. Now they are atenolol, esmolol. Now we are using nebivolol, etc. Specifically using the carvedilol, which has got the alpha and the beta blockers, both properties. Now, chronic treatment of the systolic heart failure is the correction of the systemic factors, if they are present. You will do the lifestyle modifications, lowering the salt intake and, restricted the activity, alcohol and other things. Smoking should be prohibited. Maximize medications. Discontinue those drugs which can contribute to the heart failure, like NSAIDs and calcium channel blockers, like for example nifedipine, diltiazem. They will worsen the condition. So minimize the doses. Now, out-of-drug therapy is the loop diuretics, ACE inhibitors, or ARB. If it is not tolerated, you can give the Losartan and the Valsartan. I already said about it. Beta blockers, digoxin, hydrazine, nitrates, or potassium sparing diuretics. Diuretics are loop diuretics. I already said it. Potassium sparing diuretics. ACE inhibitors are manifold. It is a big chapter. In most of the cases, I use the Valsartan or Candesartan in my practice. Beta blocker, I am using mostly the carvedilol, bisoprolol, and metoprolol, and atenolol are also using by other physicians. They are contraindicated in the bradycardia and symptomatic bradycardia. In the cases of the patient allergic type of asthma, or PR interval is much higher, 0.24, you cannot use beta blocker therapy. You can give the carvedilol. Carvedilol can be used. Hydrazine, another dose, which is cause the afterload to be reduced. It is a good drug. And isosorbide dinitrate is also doing the same, the venodilator as well as the arterial vasodilator. It will help the preload to reduce as well as the afterload to reduce. Digoxin, I already said, it will be discussed in the final year. It is a very powerful inotropic agent. The other important medication associated used to reduce the lipid level should be normal, LDL cholesterol should be reduced, the triglycerides should be reduced. We use mostly the HMG co-reductase inhibitors, that is called statins, in these conditions. To avoid most of the medication along with this condition are the NSAIDs, the thiazolidinones, like rosiglitazone or pioglitazone. It will cause the fluid retention. Metformin, again, it will cause lactic acidosis. Those patients who are diabetic and they have the failure, there are chances of the lactic acidosis. So we will not use this. Say on the safe side, if all measures are failing and there are recurrent heart failure, we use the implantable cardioverter defibrillator. Or we can use, in some conditions, even the dual chamber pacemakers can be used. Now, in this condition, implantable cardioverter defibrillator, there are 2 or 3 benefits. It will stimulate the heart. It will reduce the mortality. It will reduce the arrhythmia, and patient has got better stroke volume with the implantable cardioverter defibrillator.